Hello, everyone. So this is the recording of the video on module number 8, which is pulmonary system. And the first few slides, I'm going through the slides. It's an EMP, anatomy and physiology of the respiratory or pulmonary system. So I'm going to skip all these slides because that pertains to the anatomy and physiology. And we'll start or begin the lecture on the alterations of the pulmonary system. So the first case study here, it's about the structure of the and function of the pulmonary respiratory system. And the case study here, I'm going to answer the questions presented here, the 3 questions. The first question, how can the disease described above create a mismatch between ventilation and perfusion? And the ventilation and perfusion, there is a equation or a ratio called VQ ratio. V indicates ventilation, and the perfusion, or the Q, would pertain to or indicate the perfusion. So ventilation, the air enters the alveoli, and then or through the airways, and then to the alveoli, and then that's the ventilation, and then the perfusion. That's when there is the exchange or entailed or includes the exchange of gases between the alveoli, the air, O2 and CO2 in the alveoli, and the blood vessels in the pulmonary vasculature. So sometimes there is a good ventilation but poor perfusion, or there is other cases would be the poor ventilation and good perfusion. So that's called the VQ ratio. And when there is a mismatch, that is called a VQ mismatch. When there is a problem either pertains to ventilation or to perfusion, or both. So the first question, we can say that the chronic lung disease can cause impairments in both pulmonary ventilation and perfusion. If the circulatory, which is the perfusion, the circulation, and the alveolar tissues are destroyed, so there is problem with the alveoli, so destruction of the alveoli, like in atelectasis, for example, or there is problem in the circulatory system, so or perfusion in the blood vessels, blood clot, like in pulmonary embolism, PE, which would result in the obstruction of the pulmonary vasculature or perfusion within the blood vessels and lungs. So the alveolar dead space, which is dead space in the alveoli, it's a term that can be used to describe inflated alveoli. So when the alveoli is inflated, we will call that alveolar dead space without a local blood flow. So there is an inflation of the alveoli, so which means there's good perfusion, ventilation, but there is no blood flow, which means poor or no perfusion. And that will be seen in when the capillaries are non-functional, capillaries, blood vessels, non-functional. The physiologic shunt describes the blood supply to an area of the lung that is inadequately ventilated. So there is a poor ventilation in physiologic shunt. And that's when the lung tissue is damaged. So in both situations, the oxygenation of the blood is compromised, either ventilation or perfusion. We call that VQ mismatch. Question number 2, which is individuals with chronic obstructive pulmonary disease, COPD, they have more difficulty exhaling than inhaling. So why is this so? This will be also discussed under the COPD, the chronic obstructive pulmonary disease as well. But I'm going to answer right here is that the airway resistance is lower during inhalation because of the elasticity or elastic properties of the lung. So when inhalation occurs, the elastic fibers have the effect of pulling airways open as the thoracic cage expands. During the exhalation, the natural recoil of the lung tissue, which means elasticity, recoil of the lung tissue. So during the exhalation, the natural recoil of the lung tissue results in narrowing of the passages of the airway. Now, in obstructive pulmonary disease, it increases the airway resistance and therefore add to the resistance already present during the exhalation. So that's a problem with the COPD, chronic obstructive pulmonary disease, is that it increases the airway resistance and therefore adds more resistance, which has already been present during the exhalation. The question number 3, in general terms, what mechanisms of lung disease can affect diffusing capacity across alveolar membrane? This is called the Fick's law. We can use the Fick's law to explain the answer. The Fick's law states, which this could be or can be classified as the advanced pathophysiology. Is just an answer very quick. I'm not even asking that you know this for exams or for for the scope of this class, but it's just to know that the Fick's law states that the volume of gas moving across the alveolar membrane in a given amount of time is proportional to the partial pressure difference of the gas in question, the surface area of the membrane, and the diffusion coefficient. It also stipulates that the diffusion is inversely proportional to membrane thickness. So 2 factors, the diffusion and membrane thickness. These 2 factors, they are inversely related. So this patient, or in lung disease, we'll discuss this later on in other sections of the lecture. So the other scenario, the first question, define compliance and resistance. Now, the compliance reflects the ability of the lung to expand. The lungs can expand freely without any restrictions. That's called compliance. Compliance of the lung can be impacted by changes in the actual lung tissue with decreased elastic forces by changes in the thoracic cage. A patient with a significant scoliosis, for example, of the thoracic cage, patient with severe or significant scoliosis of the thoracic cage can have a decreased compliance, and this will be secondary to the bonus changes, which is the changes in the bone, especially the vertebrae and the spinal column, mostly in the thorax. So that's an example how compliance can be defined or can be applied to a patient with severe scoliosis, in which that the thoracic cage can have a decreased compliance secondary to the changes or alteration in the bony structure in the thorax. However, resistance in the lungs refers to the resistance of airflow and is related to the diameter of the airway. If the airway is constricted, airway is dilated. So the small decrease in the size of the airway will cause significant increased resistance to the airflow, like with the bronchospasm and the spasm of the bronchioles. So diseases such as asthma will decrease airway diameter, increase resistance to air movement, and increase wheezing due to the increased pressure needed to move air through a narrow airway. So that's the sound you're going to anticipate hearing, which is the wheezing. So Anytime you have patient with asthma, automatically one of the first signs or manifestations is a wheezing, and that increased wheezing, that wheezing respiratory sound or lung sound, that's due to the increased pressure needed to move air through the narrow airway. So the airway is narrow now, it's constricted, and that results in a wheezing sound or lung sound. So number two, um, in patients with chronic obstructive disease, COPD, there's an increase in residual volume. So how would you define, or what does that mean? Now, in patients with COPD, there is an increased residual volume. Now, in the lungs, there are several important lung volumes. Residual volume is the amount of air that remains in the lung after full expiration. So after the full expiration, um, the, the amount of air that remains in the lung, that is the residual volume. Now, residual volume cannot be directly measured. It is known that residual volume increase in diseases where there is an air trapping. So with the COPD, the patient are able to inhale, but they have a problem with exhaling or expiration, or exhaling the air taken during the inspiration. So the air being trapped in the alveoli. So that's residual volume will be increased. So they will have increased residual volume because of the air trapped in the alveoli. Now, clients with asthma and chronic obstructive disease, they will have both. They will have an increased residual volume. Number three, in patients with COPD, there's a decreased surface area for diffusion. So how that would or will impact diffusion and how that will relate to the hypoxia and elevated CO2. We have to remember that diffusion is impacted by surface area, concentration difference, and movement of the particles to be diffused. So the larger the surface area for diffusion, the more active and more effective diffusion would be or will be. In the lungs, the normal structure of the alveoli and the capillary beds provide for a very large surface area and would increase the movement of oxygen and CO2 across the cell membrane. So for that exchange of gases will take place because there is an increased surface area. So especially also with the presence of the surfactant and neonates or newborns who are premature because they have insufficient amount of surfactant, because surfactant, it's substance that increases the surface area at the alveolar membrane. With insufficient amount of surfactant, they will have a respiratory problem and pulmonary issues. So when there is a disease, the lungs that increases the size of the alveoli, it will negatively impact the amount of actual surfactant surface area, which should be available for the diffusion and the exchange of the gases, CO2 and O2. So an example of the disease that will cause a decrease in surface area, which is COPD, chronic obstructive pulmonary disease. The loss of elastic tissue, elasticity of the lungs, enlarging of the individual alveoli with decreased actual surface area, which will come into contact with the pulmonary capillaries, will decrease the effectiveness of diffusion. So the elasticity of the lung tissue is also critical, an important factor, because the loss of that elasticity of the lung tissue, it will decrease the actual surface area, which is needed for the exchange of gases to take place between the alveoli and the pulmonary capillaries. And that will lead to hypoxia and hypercarbia. So number 4, the difference between functional and the central, uh, between the function of the central and peripheral chemoreceptors. Now, the difference between the function of the central versus or the peripheral chemoreceptors, the very important concept here is that central chemoreceptors are largely responsive to the levels of carbon dioxide. So the level of CO2 affect the central receptors. So in other words, that central receptors are largely responsive to the levels of CO2 in the blood, TaCO2. Now, these are very important in the minute-to-minute control of respiration. Increased CO2 levels in the blood will increase the PA, will increase the hydrogen ion levels in the cerebral spinal fluid. That will stimulate the central chemoreceptors that are located near the respiratory center and the brain stem. So one more time, the increased CO2, which is in the blood, will increase the hydrogen ion levels in the cerebral spinal fluid, CSF fluid, and that will stimulate the central chemoreceptors that are located near the respiratory center and the brain stem. So these receptors will effectively control respiratory effort in the normal patient. So normally when the CO2 level drops, then that will result in stimulation of the respiration. So these receptors will effectively control respiratory effort in the normal patient. Now, the peripheral chemoreceptors are responsive to the levels of oxygen in the blood, not the CO2. Peripheral chemoreceptors, they are responsive to the levels of PaO2, the oxygen level in the blood, not the CO2 like in central chemoreceptors. So these receptors, which is the peripheral chemoreceptors, are located in the aortic arch and carotid body, and they respond, both of them, largely to the blood oxygen levels when they PaCO2 drop less than 60. So these receptors in the normal individual do not play a role in minute-to-minute ventilation, but it makes the major factor in the respiration in patients with respiratory problems, like patients with CO2, for example. We should not increase the CO2, to increase the oxygen deliver or oxygen concentration over higher than 2 liters per minute, because they need that small amount of CO2 present to stimulate their breathing, or the breathing center and the brain stem to be stimulated constantly with the presence of the CO2. So that's the reason why we should recommend not to increase the oxygen level higher than 2 or 3 liters per minute for patients with CO2, because of this concept in question number 4. Answers to these questions. The first one is orthopnea. It's just a concept or a term, orthopnea, which is a patient present to the physician complaining difficulty breathing when lying down. That is called orthopnea. A female with emphysema present to the ER, difficult breathing, and the bluish skin and mucous membranes, that is called cyanoses. Which statement appropriately define hypoventilation? Which is a definition of hypoventilation? It's inadequate alveolar ventilation in relation to the metabolic demands. So inadequate alveolar ventilation in relation to the metabolic demands, it correctly defines hypoventilation. The hyperopnea, which is rapid breathing with little to no expiratory pause, orthopnea, which is difficulty breathing due to body position, which is lying position. Dyspnea, which is the feeling of not getting enough air, that's called dyspnea. So these slides explain the symptoms or manifestations, signs and symptoms or manifestations of pulmonary disease. Most pulmonary disease, they will share some of these manifestations, or in other words, that these manifestations are very common in most respiratory dysfunctions, like dyspnea, for example, which is the subjective sensation of uncomfortable breathing. And that's, we have some factors like etiologies that could be, which is due to the disturbances of ventilation gas exchange, or what we have described earlier, which is the VQ ratio, the ventilation perfusion ratio, and other diseases. Dyspnea and exertion, orthopnea, and then we have the paroxysmal nocturnal dyspnea during night time or during sleep, abnormal breathing patterns, which we first one is cosmal breathing or respirations, and that's very common in patients with DKA. When they develop the diabetes ketoacidosis, they develop this type of breathing as a compensation to the acidosis to blow off the CO2, so it will correct the acidosis by blowing off the CO2. That's called cosmal respiration. So that would be an example of patients with diabetes ketoacidosis, because they will have the ketone bodies, and the ketone bodies are a source, considered as a source of the acidosis, and makes the blood acidotic. So the lungs attempt to breathe faster, so that's called cosmal, and in order to blow off the excess of CO2, so it will correct the acidosis by the hyperventilation. Second, we have another type of respiration called Cheyne-Stokes respirations, and that characterized by alternating periods of deep and shallow breathing. And this is the exact definition of Cheyne-Stokes respirations. And the contributing factor is the neurologic impairment that would affect the above brain stem. Hypoventilation and hyperventilation. We have some causes and etiologies for both. And then cyanosis, bluish discoloration of the skin and mucous membranes, and the causes or etiologies here listed as the decreased arterial oxygenation, PaO2, the cardiac right to the left shunt or pulmonary shunt, decreased cardiac output called environment, and anxiety. Then we have a definition of the peripheral cyanosis. Clubbing, which is one of the common manifestations of long-term hypoxia or hypoxemia. So patients with COPD, for example, they tend to develop this clubbing. That's a long-term. It doesn't happen like over a day or two or a week. It takes a long time to develop. That's one of the long-term complications, or you can call it a manifestation of chronic hypoxia. And sometimes also it's seen in patients with lung cancer as well. Chronic hypoxemia would lead to clubbing. Cough, also another known or common manifestation to different pulmonary diseases. We have acute cough, and then how would you differentiate that from the chronic cough? Hemoptysis, and we have to differentiate between hemoptysis and hematemesis. Hematemesis, that's is the vomiting, vomitus with blood. when the patient vomit, vomitus with blood or bloody vomitus, that is hematemesis. Hemoptysis, that's coughing with blood, coughing with blood. Cough up of blood or blood secretions, that's hemoptysis. And that's common in the patients with the pulmonary dysfunctions. Other symptoms, abnormal sputum, like for example, in patients with tuberculosis, pulmonary TB, they would have the, we test for sputum for the AFB, and we will get to that, and different colors of the sputum that indicates also different infections. Pain is known as one of the manifestations of pulmonary disease. Hypercapnia, and that's due to the accumulation of the CO2, and that would due to the hypoventilation. CO2 retention or accumulation result in a hypercapnia, increased CO2 in the blood. Hypoxemia, we have the differentiation between hypoxemia versus hypoxia. And we have, I explained the shunting in the previous slides about the mismatch of the VQ ratio or mismatch of VQ, and the shunting and the definition of the shunting in the previous slide, one of the previous slides. Hypoxemia, so this is the distinction or the difference between hypoxemia and hypoxia. And alveolar dead space, I also give or provided a definition for that as well in the previous, one of the previous slides. This figure explains the VQ ratio, normal VQ ratio right here. So the air entering the during the inhalation, the bronchial tree and dental alveoli, that is ventilation, and then the exchange of gases, that is will be affected by the perfusion within the pulmonary vasculature or capillaries. So that's perfusion, or Q, indicates Q, and the V, ventilation, and then perfusion. So we have examples of the low VQ and the shunt, very low VQ, and then the high VQ. When there is the airway and there is over distension of the alveoli. So another slide describe or define the dead space, the physiologic dead space, pulmonary edema. So that's when the patient experienced the excess of the water or fluids in the lungs. And the precipitating factors, what would predispose or precipitate this disease, mostly cardiac, like CHF, for example, acute respiratory distress syndrome, ERDS, inhalation of toxic gases, that will result in pulmonary edema. And eventually, these are the factors that will result in pulmonary edema. Blockage, which is obstruction of the lymphatic vessels, obstruction or blockage, injury to the capillary endothelial lining of the capillaries in the lungs, or valve dysfunction. dysfunction of the valves, coronary artery disease, CAD, like patients with angina, for example, or CHF, or left ventricular dysfunction. An example of that would be the CHF. Aspiration, which is defined as the passage of fluid and solid particles in the lungs. So patient would develop this. The first most common factor, and this is very common, the most common factor, which is the altered level of consciousness. It can be due to substance abuse or to any other factors. Sedation or anesthesia, seizures or seizure disorders or epilepsy, CVA, and the patients with a PEG tube, for example, gastrostomy tube, they will be at risk for aspiration. So to maintain the aspiration precautions, that will be the first thing as a nurse, to maintain aspiration precautions for patients who are having a change or altered mental status, or patients with altered level of consciousness, patients who are sedated or under anesthesia, especially general anesthesia, patients who would develop seizure attacks or episodes, patients with a CVA also. So maintain head bed elevated, that will be to prevent aspiration. These are the preventive measures to prevent the aspiration. And also aspiration would result in patients with a swallowing problem, when they have a swallowing problem or difficulty. So due to any of these, especially for like stroke or CVA, then we have to maintain head bed elevated. We have to we have special guidelines from the speech language pathologist about the positioning of the patient, the special technique how to feed the patient, and the consistency of food that the patient should ingest in terms of fluid, like liquid to be thin or to be thickened, or the solid food to be pureed diet or semi-solid, or so there are the specific, special or specific guidelines in terms of the consistency of fluid and solid food. Atelectasis, which is the collapse of the alveoli. We have different types of atelectasis. Absorption atelectasis, which will result from the removal of the air from obstructed hypoventilated alveoli. And post-op, that would be one of the risk factors or complications. Post-op is the atelectasis. We will skip this one. Atelectasis, two different types of atelectasis. A, which indicate or describe the absorption atelectasis. And then B is the restoration of the collateral ventilation during the breathing. But both they describe the absorption atelectasis, which would result from the removal of the air from obstructed or hypoventilated alveoli, or sometimes from the inhalation of concentrated O2 or the inhalation of the anesthetic agent. That's why patients could develop this due to the inhalation of anesthesia. So post-op would be atelectasis, post-op atelectasis, if develops as a complication, that's due to the inhalation of the general anesthetic substance. Pneumothorax and hemothorax. The pneumothorax, which is air entering the pleural cavity, and we have different types of pneumothorax: open pneumothorax, tension, spontaneous, secondary pneumothorax. Pleural effusion, which can also be classified as the effusion of fluid, or like transfusitive or exudative, like an exudate, which is would be white blood cells, plasma, proteins, or blood, like hemothorax, or pus drainage around the lungs, pleural effusion of from the bacteria and the pussy fluid around the lungs, that is called infected pleural effusion, which is empyema. So empyema means pussy drainage. That's the fluid around the lungs. That's pleural effusion. But again, we have different types. Empyema, when there is the bacteria and the pus would form from the bacterial infection. And then the chylothorax. Next is the flail chest, which would result from the fracture of several consecutive ribs or the fracture of the sternum and ribs. So the fracture of the ribs will result in flail chest. So these type of fractures that affects the ribs, that will result in the instability of a portion of the chest wall, and what would cause something called paradoxic movement of the chest with breathing. One side will, like for example, normal respiration, A, and B. Inspiration, inflation of the lungs, and then expiration, air leaves and exit the trachea from the lungs. Now, C, it shows the paradoxic motion. So inspiration, area of the lung underlying unstable, chest wall will be sucked in during the inspiration. And then D, expiration, that's an inspiration. And expiration, the unstable area, it will balloon out. So that's called paradoxic motion. During the inspiration, sucked in, and then the affected, which means it's just the affected part. And then during the expiration, it will balloon out. So this is called paradoxic motion that will take place during the flail chest. It's an emergency condition or situation, and should be taken care of as mostly due to trauma. The flail chest would develop due to chest stab wound or gunshot or trauma to the lungs. Acute respiratory distress syndrome, the ARDS, and that mostly due to the injury to the pulmonary capillary endothelium, or due to the surfactant inactivation, like the surfactant is inactive. Like we give an example of the newborns who are premature, they don't have enough surfactant substance or material that will increase the surface area at the alveoli. So that will result in acute respiratory distress syndrome, ARDS. And they will, so the neonate and premature babies, they will receive the surfactant as a medication, the supplement during, the treatment. regimen. That also could result from atelectasis, the RDS. So the acute usually is caused by acute air respiratory failure, which usually will be caused a result from direct injury to the lungs, injury to the airway, or injury to the chest wall, or indirectly injury to the brain or spinal cord, and then eventually it will affect the lungs. Some post-op respiratory failure that will result due to the atelectasis, pneumonia, pulmonary edema, pulmonary embolism, and these some of the preventive measures. I believe that you covered this in Adult Health 1. Now, obstructive pulmonary disease, COPD. So we are going to cover under the obstructive pulmonary disease, asthma, chronic bronchitis, and emphysema. The chronic bronchitis and emphysema both can be listed under the COPD, but asthma is different. In other words, that the asthma, the pathophysiology of the asthma disease is different from the pathophysiology of COPD, which would include chronic bronchitis and emphysema. And just remember that the asthma from previous chapters that be triggered by the IgE antibodies. So it has an allergic type of reaction, type 1 hypersensitivity reaction. So asthma, when we describe the pathophysiology of asthma, we'll start from the allergen or the exposure to the irritant or to the allergen that will trigger the immune activation, mast cell degradation, and then the chemotactic factors, and then the especially the histamine, and then that will result in vasoactive mediators to be released, and then we have the all the manifestations of the asthma, bronchospasm, secretions, the narrowing of the airways, the thickening of the airway wall. All these will result the constriction of the or contraction of the smooth muscle of the bronchioles, and that will result in a bronchial hyperresponsiveness, airway obstruction. So the asthma, the high morbidity rate, that's due to these factors, 7 factors. So the etiology and genetic risk of for the development of asthma starts with genetics in terms of the etiology and the genetic risk. So the genetics, which results from the genome-wide association studies. These studies indicate more than 50 gene variations responsible for the development of asthma disease as genetic predisposition. The etiology, the allergens, there are different allergens, too many. Each, like, some patients, they would be allergic to animal dander, for example, dust mites, pollens, mold. All of these are going to exaggerate the immunoglobulin IgE response. And then the asthmatic attack would follow or result. The exercise, when exercising in cold, dry climates, breathing through a mask, for example, it may decrease likelihood of symptoms. So the mask is protective for um, asthmatic patients or patients with asthma, because especially when they are in climates that will trigger the asthma, cold or dry climates. So breathing through that mask, it will decrease the likelihood of symptoms. So it may alleviate some of these asthmatic asthma symptoms or manifestations, especially the wheezes, the bronchospasm, and the difficult breathing. The respiratory infections also can be a etiological factor because they are most common precipitating factor of an acute asthma attack, the respiratory infections, because the inflammation would increase the hyperresponsiveness of the bronchial system. Other triggering factors like the nasal or nose and sinus problems, the large polyps, when removed for the asthmatic patients or asthma patients, the removal of these polyps, it have a good control and promising results in terms of the frequency of the asthmatic attacks and the control on the for the asthma disease. So the removal of these large polyps for the asthma patients can be have resulted in a good control of the disease. Other triggering factors like aspirin and NSAIDs, non-steroidal anti-inflammatory drugs, they will result in wheezes that may develop within hours, within like 2 hours. So if patients are allergic to salicylates, like aspirin, for example, and that is a triggering factor for them, the salicylates, and it will inhibit the adrenergic stimulation of the bronchioles. The ACE inhibitors some patients are, you will cover this in pharmacology about the ACE inhibitors, and some patients are people even with no history of asthma, they tend to have tendency to develop dry cough, dry non-productive cough, especially like nighttime, and that's due to the mechanism of the ACE inhibitors, angiotensin converting enzyme inhibitor. And we will cover this in pharmacology class or course. And so patients with asthma, probably they are going to have even worse symptoms from these classification of drugs. We have also food additives that could result in a reaction within like 15 minutes up to 3 hours. And the reaction would be marked with rhinorrhea, like drainage from the nose, or secretions from nasal secretions, nausea, vomiting, intestinal cramps, diarrhea. These would result from as a reaction or response to the certain drugs or food additives. So patients with asthma face a response to asthma. Patient experience like wheezes, cough, chest tightness, dyspnea. These are known manifestations and as associated with asthmatic attack. The release of the inflammatory mediators like histamine. The major one is histamine, but we have also other chemical mediators like bradykinin, leukotrienes, prostaglandins, and cytokines. So if the airway inflammation is not treated or doesn't resolve, that may lead to irreversible lung damage. Now, chronic bronchitis and emphysema both belong to or can be classified under the COPD, separate from asthma, because asthma, pathophysiology of asthma is different. So COPD, which includes chronic bronchitis and emphysema. So the COPD is characterized by the presence of airflow obstruction, either due to emphysema or chronic bronchitis, called COPD. It's the fourth leading cause of death in the US. So the criteria to diagnose or to diagnose patients with COPD, the criteria is the presence of chronic productive cough for 3 or more months in each of 2 successive years, in a patient who uh, doesn't have other diseases, in which that whom other cause of chronic cough have been excluded. So the patient who would experience the chronic productive cough for 3 or more months in each of 2 successive years, that can be classified as patient with COPD, diagnosed with COPD. But we have to exclude the other causes of chronic cough, like for example, heavy smokers, like tobacco smokers, they will have that chronic cough. So the cigarette smoking as the first contributing factor or etiological factor for COPD, and this slide explains very well and clearly describe in details about how the smoking or cigarette smoking will lead to COPD and the detrimental effects of the tobacco or cigarette smoking. Now, COPD, there are other factors or etiological factors that would contribute to the COPD, like the antitrypsin deficiency. So this is something cutting edge, like new science. They found that the alpha trypsin deficiency is the only known genetic abnormality that lead to the COPD. So there is a genetic tendency or predisposition that's in patients with the alpha antitrypsin deficiency. They are more susceptible to develop the COPD. So normally the alpha antitrypsin is produced in the liver and normally found in the lungs. And the AAT deficiency will lead to premature emphysema, which means COPD. So emphysema, which is the abnormal permanent enlargement of the gas exchange airways, and that is accompanied by the destruction of the alveolar walls without obvious fibroses, as the previous slide states. So there is in the emphysema, there is a loss of elastic recoil, and the patient will develop what is called the battle chest. And that's because of the air trapped in the alveoli and difficult to exit all the air trapped. So that's why there is an increased residual volume. Residual volume will increase constantly because of the inability to have effective exhalation. So more air will be trapped in the alveoli, and that will result in a better chest. Um, the two different types of emphysema, centrilobular and panlobular. The panlobular, which is a destruction of the whole lobule, um, usually it's found in patients with alpha antitrypsin deficiency. So those patients with alpha antitrypsin deficiency, if they develop the COPD, they tend to have this type, which is the panlobular emphysema type. So the destruction of the alveolar tissue will result into inflammation, exudate formation, which is the excretion of the or drain of fluid or secretions, exudate, and then edema, like pulmonary uh, edema. Now, the air trapped in the alveoli from ineffective exhalation will result in hyperinflation of the alveoli and over distension. And that's, again, explains the barrel chest that patients will exhibit or will develop over time from the emphysema, or we call it COPD, but it's one type of the emphysema is one type of COPD. So they exhibit or manifested with dyspnea, difficult breathing. Patient will first complain of the dyspnea and exertion, and that then progress to interfere with patients' ADLs and patients at rest. So chronic bronchitis, which is the hypersecretion, the distinction between emphysema and the chronic bronchitis is that in chronic bronchitis, that's the key, which is the hypersecretion of mucus and chronic productive cough. We don't expect or anticipate patients with emphysema to have this specific manifestations, which is the hypersecretion of mucus and chronic productive cough. So chronic bronchitis would be indicated when the patient develop a hypersecretion of mucus and chronic productive cough. Most of the time, it's very difficult for practitioners to differentiate between emphysema versus chronic bronchitis. That's why in the chart you will see just COPD without any specific, like or alluding to or indicating if that's emphysema or chronic bronchitis. They would just say COPD, but that could be emphysema or chronic bronchitis. So chronic bronchitis, because the increased and excessive amount of secretions, frequently airways are colonized with microorganisms. Colonized means there is bacteria, there's microorganism, but it's not active. It's colonized, like spores. Um, so the excessive amounts of mucus are found and may occlude the small bronchioles. And the occlusion of the small bronchioles that will interfere with the normal ventilation and normal exchange of gases. ventilation and mostly with ventilation. Chronic bronchitis, so the mucus will interfere with the ventilation, so it will become like a physical barrier to ventilation. So the patients, they have ineffective cough, and it's ineffective to remove secretions because the patient cannot breathe deeply enough to mobilize the secretions and enough to cause the airflow distal to the secretions in order to expectorate these secretions. So the cough is ineffective to remove the secretions. The bronchospasm frequently develops and usually more common with history of smoking or with asthma. Early symptoms of in patients with chronic bronchitis. Now, hemoglobin may reach 20 grams per dl or more, which means patient have a polycythemia vera or polycythemia. Polycythemia means elevated hemoglobin. And why would a patient with chronic bronchitis, and that could also result in patients with, or from the complication from patients with the emphysema. So COPD, emphysema, or chronic bronchitis, hemoglobin elevation that so patients who tend to develop the polycythemia, elevated hemoglobin, that's because patients with chronic hypoxia, they tend to, the bone marrow will produce more RBCs, red blood cells, as a compensation to the chronic hypoxia. So that's called polycythemia vera. That's from the hematology chapter, polycythemia. And polycythemia also would result or may develop in patients who live in high altitude. As we move higher, live higher than the sea level, more than like 10,000 feet above the sea level, that will result in a decreased oxygen in the higher levels. So that's high altitude patients who live in high altitude, they tend to develop also polycythemia vera, polycythemia, and elevated hemoglobin. So elevated hemoglobin here in COPD, that's from the chronic hypoxia. And the bone marrow will compensate by producing RBCs to compensate for the decreased oxygenation or hypoxia. So the patient with COPD, if they have an elevated hemoglobin of 20, 21, or 22, that is expected. Diagnostic studies. One of the diagnostic studies, which is typical finding, is called FEV, forced expiratory volume, / FVC, forced volume capacity. The FEV / FVC, a ratio of less than 70. So because the number here will be a ratio. So the ratio of less than 70 would suggest the presence of the obstructive lung disease. And I'm just going to write the ratio right here on the whiteboard, or I can just type it. Just the FEV. I'm not sure it's not typing. So it's the forced expiratory volume in relation to the forced volume capacity. So there is a ratio, and anytime the ratio is less than 70%, that will indicate or suggest the presence of chronic obstructive disease, COPD. So we know that the ABGs from the first few lectures, that the PaO2 will be decreased, the PaCO2 increased, elevated, and then the pH will decrease because of the hypercapnia, which is increased CO2, that will result in acidosis, and there will be, in the late stages, the compensation will be by increased bicarb levels. So the bicarb here, the increase, that will be in late stages of COPD as a compensation. So the case study number 3, which is about asthma, I'm going to answer the questions. I believe the answers are provided, so you can read it in your own. Next case study, another one on asthma as well. So that's about 5 years old boy who has admitted to the hospital with diagnosis of asthma. So the nurse notes the increased respiratory rate and wheezing throughout all lung fields. The first question, how would you explain the signs and symptoms noted by the nurse to the pathophysiology of asthma? Now, the asthma is an airway disease. So there's a hyperresponsiveness of the airway. So asthma is an airway disease. There are two important components. The first is increased airway reactivity. That's what we call a reactive disease. So there is the first component of to understand asthma is that there is an increased airway reactivity, which is associated with the bronchoconstriction. The bronchoconstriction would result in an increased airway reactivity. When the patient, obviously this results when the patient is exposed to the allergen or irritant substance. The second important component is the inflammatory response. So the first one is the increased airway reactivity that is associated with the bronchospasm or bronchoconstriction when exposed to the allergen or the irritant. Now, the second component, which pertains to the inflammatory response that occurs with increased swelling of the airway. So when there is increased swelling and edema of the airway due to the inflammatory response, there will be also, because of the inflammation, there is an increased mucus production, and chronically with actual changes in the smooth muscle of the airway. So these are the two main components in understanding the asthma. So in this case, you can see the patient has an increased respiratory rate, a frequent cough, increased wheezing noted by the nurse when examining the patient. The increased respiratory rate can be related to the hypoxia, secondary to the increased airway resistance and decreased airflow. Cough is it's a defining symptom of asthma and is related to both the bronchoconstriction that occurs as well as the increased inflammation, which is the inflammatory response with narrowing of the airway. The narrowed airway constriction, bronchoconstriction, or the narrow airway will stimulate the irritant receptors and will increase the severity of the associated cough. Wheezing initially occurs during expiration. The airway elastic fibers will increase the size of the airway in inspiration, but during normal expiration, the airway will decrease in size. So just to know that the two main components of the asthma, which is the first one we said, it's the increased airway reactivity, which is associated with the bronchoconstriction when exposed to the allergen or the irritant substance. And the second component is the inflammatory response that will take place with increased swelling of the airway, increased mucous membrane or mucus production, and that will result in long-term chronically to actual changes in the smooth muscle of the air, which is the more hyperreactivity and hyperresponsiveness of the airway. And the resultant manifestations will follow these two mechanisms. Number two, does the child more likely have intrinsic or extrinsic asthma? Now, the extrinsic asthma symptoms occur in response to the allergens. Extrinsic asthma will result in response to the allergens, like dust mites, the pollens, the mold, cold climate. It's also called allergic asthma. You can call it extrinsic asthma or allergic asthma. And the most common form of asthma is the extrinsic asthma. We always refer to the asthma as, we say asthma, but there are two different types of asthma, intrinsic or versus the extrinsic. Extrinsic is the most common type, and that's the asthma that results in response to the allergens, the pollen, mold, or cold climates, or dust mites, or these are the triggering factors. So that's called the allergic asthma or extrinsic, and that's the most common type of asthma. The intrinsic asthma, which has a range of triggers, there are triggering factors as well, like the so that's incorrect when I said the weather or the cold climate. The weather conditions belong to the intrinsic, actually, not the extrinsic. The cold or weather conditions, a cold climate, or in addition to the exercise, for example, infections, stress. If the stress, exercise, cold weather, or weather conditions, exercise, infections, or stress result in asthma or cause asthma, that is called intrinsic asthma. And people will call it non-allergic asthma. So asthma that will result from dust mites, pollens, mold, even some people, they develop that develop the asthmatic attack due to the exposure to getting contact with close to the cockroaches, which is unusual, but that's one of the also triggering factors. So pollens, mold, dust mites, cockroaches, and other, that is called extrinsic asthma. The intrinsic is when the patient is exposed to the weather conditions, exercise, infections, stress, that is called non-allergic or intrinsic asthma. So back to our case scenario. Because of the age of the child, you would pick like extrinsic asthma. The extrinsic asthma is associated with allergy and is stimulated by type 1 hypersensitivity reaction. So type 1 reaction will cause a degeneration of or degradation of the granulation of the mast cell. and then it will release the chemical mediators, chemicals, then result in bronchospasm. So that is extrinsic asthma. So the patient has extrinsic asthma, not the intrinsic asthma. The other symptoms, what other symptoms of asthma you would monitor as a nurse. So it is very important for the nurse to monitor for signs of hypoxia. The patient can have a marked increase in respiratory rate and increased use of accessory muscles. Hypoxia can affect the mental status with changes in the level of consciousness. Patients, they tend to be initially anxious and restless with increasing hypoxia. Also, you may anticipate patient to have a fatigue, being lethargic, decreased mental status, and that's all these manifestations would result from or due to the hypoxia. The last question pertains to the medications, which is pertinent to the pharmacology course, but I will just briefly go over the answer here. The quick control medication, which you will call it in pharmacological, it's called rescue meds. Or quick control medication is always bronchodilators, like albuterol, for example. Albuterol is a bronchodilator that is going to be used as a rescue med or a quick control of the asthmatic attack. So that medication would be ordered if the patient is in trouble with increased respiratory effort and increased bronchospasm. The medication can be used short-term to control the symptoms. But the steroids, corticosteroids, inhalation, corticosteroids, it can be also used, but long-term control medication, not as a quick control, or rescue med, but as a long-term control medication, or as a maintenance dose, like a daily, not in response to a asthmatic attack, but that will be given in a daily dose, and that's for long-term control medication called inhaled corticosteroid. And you will cover all of these in medications and pharmacology course. Pneumonia, there are different types of pneumonia, and that's the acute inflammation of the lung parenchymal tissue. And most frequently will be caused by microorganisms. But also there are different types of pneumonia. For example, before we go into the different types, the other diseases that may, in terms of the etiology, that will lead to the pneumonia, like the altered oropharyngeal flora, can occur after a patient had received antibiotic therapy. So patients who would receive the antibiotic therapy and that flora, normal, bacteria, non-harmful bacteria that will in the oropharyngeal secretions that become harmful after the patient received the antibiotics, especially with the broad spectrum. So this flora becomes infectious, and that could result in pneumonia. The different types of pneumonia, like community-acquired pneumonia, we have the hospital-acquired pneumonia, ventilator-associated pneumonia, and the healthcare-associated pneumonia. Now, the healthcare-associated pneumonia, which is a new onset pneumonia in a patient, for example, patients who develop a new onset of pneumonia, patients who reside like in long-term care facility, like a nursing home, that will be healthcare associated pneumonia type. Patient who attend like hemodialysis, patient with end-stage renal disease, and they attend hemodialysis, that is called health and developed pneumonia. That would be a healthcare associated pneumonia, the HCAP pneumonia type. Aspiration pneumonia, conditions that may would increase the risk of aspiration, like decreased level of consciousness, like due to seizure, anesthesia, head injury, stroke, alcohol intake. All of these factors will result in a decrease and altered level of consciousness, and that will result then eventually lead to aspiration pneumonia. Or patients with a difficulty swallowing, like patients with stroke, patients with a nasogastric NG tube or with gastrostomy tube, or any tube. We use different tubes for feeding. So those patients will be at risk for aspiration pneumonia. Opportunistic pneumonia, which is another type of pneumonia that will develop in patients who are immunocompromised, like patients with HIV/AIDS, for example, they develop the PCP, pneumocystis carinii or Girovisi pneumonia. And this type of pneumonia is known among patients who are immunocompromised, especially HIV/AIDS patients. This is the pathophysiology, the 4 steps of pneumonia when pneumonia develop. And then the last topic here, which is the TB tuberculosis. So while we answer the questions on the case studies, then we will be able to explain all the concepts under the TB or on the content of tuberculosis. So a nurse admitted a patient to the hospital with the possible diagnosis of active tuberculosis, TB. The patient was noted on admission to have a fever of 99.9 Fahrenheit. The patient has a cough with hemoptysis. On physical examination, the nurse notes an increased respiratory rate of 24, crackles in the lungs, and irregular heart rate of 88. Now, describe the pathogenesis of primary tuberculosis. Now, I'm just going to go back to the pathophysiology of this figure. This describes or explains very well the disease process of the TB, pulmonary tuberculosis. So the primary tuberculosis initially, so describe the pathogenesis. Initially, the primary tuberculosis initially infect the respiratory macrophages as inhaled droplets into, it will enter into the pulmonary tree, which is respiratory tree, and the lungs and bronchioles. And so the that's primary TB, primary pulmonary tuberculosis, TB, initially infect the macrophages in the lungs as inhaled droplets enter into the pulmonary tree, bronchioles and the trachea and bronchioles. Then the macrophages, then they will stimulate the cell-mediated immune response with increased number of T lymphocyte. So it's a type 4, not which is cell-mediated. So the macrophages then stimulate the cell-mediated immune response with increased number of T lymphocytes being sensitized to the tuberculin antigen. The T lymphocyte or the T lymphocytic response, then increase the ability of the pulmonary macrophage to destroy this antigen, tuberculin antigen, by increasing the activity of the lytic mechanism enzymes. So the release of these lytic enzymes, it can also cause some destruction of the normal lung tissue. So we have macrophages, inhaled droplets entering the bronchial tree. These macrophages stimulate the cell-mediated immune response and become being sensitized to the antigen. The lymphocytic response then increase the macrophage to destroy the antigen by increasing the activity of these enzymes. So the enzyme can cause some destruction of normal lung tissue. And if the patient has a strong cell-mediated response, the pulmonary macrophages will wall off the tuberculin antigen. And this is what is called granulomatous lesion. So patient is healthy, nutritional status, healthy person, they will have that pulmonary macrophages, it will wall off the antigen, and it will form the granulomatous lesions. So about 5% of individuals, the primary infection will not be walled off, and there will be continued destruction of the lung tissue and spread of the infection to new areas of the lung and other organ systems. So that's when we see it's dormant, the lesions are dormant, it's going to also show in the X-ray once the patient is infected with TB, then will continue to be present as granulomatous lesions in the X-ray. And the question number two, which is what other signs and symptoms should the nurse ask about during the admission history? So understanding the manifestations or clinical manifestations of tuberculosis is critical. The patient will complain of cough, fever, night sweats, fatigue, anorexia, malaise, general weakness, hemoptysis. The symptoms are often subtle in the beginning. That are not very obvious, very evident in the beginning of the illness. So the spread of the infection will increase the likelihood of the bacilli, which is the bacteria present in the sputum of the infected person, with increased cross-infection to infect others, to be contagious. So the sputum and the will be tested for AFB, acid fast bacillus. So that's the exact testing for the TB when we test for sputum or AFB, acid fast bacillus. So the spread of the infection will increase the likelihood of the bacilli present in the sputum of the infected person. The number three, the patient had a positive PPD 4 years ago, but was found not to have active TB. So what does a positive PPD mean? Now, the patient, so 4 years ago, the patient had a positive PPD. So when the positive PPD was found, the patient would have had an X-ray and no evidence of the disease. So this disease wasn't active. So no evidence of the disease was found on X-ray. So the patient would be considered to have latent TB. So patient infected would have been treated, and then patient no longer have an active TB. So that's latent TB. In this case, the cell-mediated response was effective, and the patient did not develop further disease. The immune system was sensitized to the antigen with the initial exposure, and when the patient is given a small amount of the antigen, which is the PPD, purified protein derivative, the PPD, that's the abbreviation of PPD. So again, the immune system was sensitized to the antigen with the initial exposure, and when the patient is given a small amount of the PPD, which is the antigen, an immune response occurs, will develop, and there is documented erythema and induration at the site. So there will be the response to that, which is a type 4 delayed hypersensitivity reaction, type 4 will develop. So that's erythema will develop, and the induration, we have to measure both the induration, the raised area, and the erythema, the redness as well. That goes also with the within the measurement. So the after you inject, and you will read it after. So that's delayed reaction because we know we read it within 48 up to 72 hours after the injection of the tuberculin test. So 4 years later, the patient now has an active case of TB. Due to the knowledge that the patient did have an exposure to TB in the past, the new onset of symptoms can be considered a reactivation of the disease. So reactivation of TB occurs with a decreased effectiveness of the immune system. So their action won't be strong or potent enough because the immune system is compromised. So reactivation of the TB usually occur with a decreased effectiveness of the immune system. This will occur with malignancy, neoplasm, chronic use of steroids. Those are patients, who will have reactive, who will tend not to have a very strong reaction. Patients with because the immune response is not strong enough. So patients with malignancy, cancer, who use steroids like chronic use, especially chronic use of steroids, corticosteroids, patients with marked nutritional deficiencies, or patients with a compromised immune system. The immune system is, for example, in HIV/AIDS patients, for example. So the reaction would not be strong enough, and the induration and redness will not be large. Number 4, the patient was diagnosed with a multiple drug resistant TB. How would this diagnosis impact treatment and change nursing interventions? So this, again, that's another question that that pertains to the pharmacology, and we treat the TB usually treated with 4 medications. It's like a course of 4 medications. It will start or begin with the INH, which is isoniazid medication, rifampin, another medication, ethambutol is another medication, pyrizdamol, another med. So we have 4 different meds to treat the TB. And we use 4 medications to prevent that resistance, to trying to prevent the multi-drug resistance TB. And the last content area will be lung cancer. And we have a few slides describe lung cancer here. The different types of lung cancer, the manifestations, etiological factors, pathophysiology. So the assessment of the risk of lung cancer, it can be also divided into like two. If the patient is smoker versus non-smokers, like smokers people who are currently smoking versus the non-smokers who formerly smoked, and there's another third classification who never smoked. So the assessment of the risk of lung cancer that was divided into three categories. The first one, the smokers, non-smokers, and then the third one, never smoked. The exposure to these substances like asbestos, radon, the nickel, or all these substances, chemicals. So the exposure to these substances that will be common in employees of the industrial area, or different industries um, um, who are being exposed to like these chemicals, petroleum, like in patients people who work like in petroleum manufacturing, for example, they'll be exposed to these chemicals. But smoking, it will have a synergistic effect with the exposure to these, or with the effect of these chemicals.